Okay, sir. So we are live now. You can go ahead, sir. Thank you.
Yeah, good evening and welcome to the expert crosstalk on the Empagliflozin, multi-mechanism, multi-indications, and multi-benefits. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which will bring upon two different ways to address the clinical complexities of the clinical cases in heart failure. So according to EMPA-REG trial, the SGLT2 inhibitor can be considered as an important drug for heart failure. And for this, let me introduce today's speakers. Today's speakers are Dr. Sandeep Chopra and Dr. Jagan Jacob, and I'm at moderator Dr. Shavik. Dr. Jubin Jacob is a professor and head endocrinology, endocrine and diabetes in the Christian Medical College, Punjab. Dr. Jubin has several international publications in his credit and has contributed several chapters in several medical books and also published books on endocrinology. I welcome Dr. Jubin in this expert web talk. Our next speaker is Dr. Sandeep Chopra. Dr. Sandeep is Additional Director Intervention Cardiologist, Fortis Hospital, Ludhiana. Dr. Sandeep has received several prestigious awards to date and has several national and international publications in his credit. I welcome Dr. Sandeep in this expert web talk, and I am handing over the session to Dr. Jubin to start with the presentation. Thank you.
Thank you, Shavik. I think it's an interesting type of meeting we are having. I think empagliflozin has shown benefits beyond, I mean, it was essentially a diabetic drug, but it has shown benefits beyond diabetes. And I think the topic is very valid, multiple mechanisms, multiple indications, and multiple benefits. Now, recently I got an opportunity to put all these things together. And if you look at the potential uses, so I think right now we have a seminar with a cardiologist and an endocrinologist. I can see empagliflozin being used in non-diabetic kidney disease very clearly. So I'm sure nephrologists are going to be on board very soon. There is enough arguments for using empagliflozin in non-alcoholic fatty liver disease. So I can see it involving gastroenterologists, obesity. We know that canagliflozin is approved in a higher dose for obesity. Obstructive sleep apnea, this is something that is very interesting that has now come up again from the EMPA-REG trial, that patients who had obstructive sleep apnea did much better when they were on empagliflozin compared to placebo. Polycystic ovary disease, there are a few papers coming, so we should have gynecologist on board. There is even one very interesting paper on the use of empagliflozin in patients with syndrome of inappropriate ADH secretion, that is patients with hyponatremia, euvolemic hyponatremia. Again, that is one area where there may be more interesting papers coming along, but I think two areas where we initially thought that they might be useful. One is type 1 diabetes. I think more or less people are giving up on that. You must have heard that sotagliflozin did not get the approval for type 1. TAPA is currently approved for type 1, I think, but as clinicians, we are very, very scared of using it in type 1 diabetes. So I think it is not going to be a drug that is going to work or be used commonly in type 1 diabetes, other than some obese type 1 might use it. So I think there is a potential. You can see that there is a whole multitude of specialties empagliflozin can be used. But today it's my job to just limit myself to endocrine and diabetes perspective. And I think if you have been a practicing physician, practicing diabetologist for the last 4 years, 5 years, you would have seen almost all of these slides. You cannot have missed any of these slides that you're going to see. But I think just to modulate, these are in terms of metabolic milieu or in terms of my endocrine things that I need to set right in a patient. You can see that we started with glucose. We wanted to improve insulin resistance. We wanted to control glucose, that is right in the center. But we also realized this, because you're losing calories, this is going to lead to some weight loss, and that you can see most of that weight loss is going to be fat. And so there is going to be a decrease in visceral adiposities. Subsequently, we also learned that it could improve blood pressure. I think this was with the initial approval itself, we saw that both diastolic and systolic blood pressure was decreased with this drug. And with the EMPA-REG and the cardiovascular outcome, we realized that it also decreases sympathetic nervous activity. It reduces uric acid. It reduces oxidative stress, in terms giving rise to what we know now as cardiovascular benefits. Subsequently, in the sub-study of EMPA-REG trial, we saw that it also did benefits in terms of renal protection. It preserved the ejection fraction. It reduced albuminuria. And there were some controversies about what it did to lipids. Essentially, there was an increase in LDL cholesterol, but that was compensated very much by decrease in triglycerides and improvement in the HDL cholesterol itself. On the whole, not either positive or negative, not doing harm. I'm not sure whether it is doing any good. But because it is doing good in cardiovascular disease, we can assume that the lipid derangements are not really having an impact, an adverse impact on our patients who are on empagliflozin. So with this in mind, just to tell you the benefits that the SGLT2 inhibitors have on heart failure. Now, when I'm talking here about heart failure, I'm essentially talking about heart failure in patients with diabetic heart disease. I'm not talking of heart failure in patients without diabetic heart disease. And we know that the mainstay in these patients were drugs like AC inhibitors and ARBs. And I think we have seen in the last few years the new drugs like ARNI, which is a combination of ARB and a neprilysin inhibitor. And we saw that it did improve natriuresis, it improved cardiac and cardiorenal physiology, decreased the preload on the heart, the afterload on the heart, and decreased the stress on the LV walls itself. But I think what SGLT2 inhibitors does is it combines the benefits that we saw with AC inhibitors and ARBs, and the benefits we saw with mineralocorticoid antagonist and diuretics. That means it reduces interstitial edema, and it does almost all the things that the current drugs for heart failure does. So it just adds. It is probably not even the icing on the cake. It supports each and every other drug that we use currently in the management of heart failure. Now, coming back to the beginnings, we all, I think, if you have been around, you have attended some webinars, you all know how SGLT2 inhibition works. It works by reducing the reabsorption of sodium and glucose, and by doing that, there is glycosuria that is produced. And of the filtered glucose load, about 180 grams, you end up losing 30 to 40 grams in the urine every 24 hours, which in turn leads to better glucose control. And that is the reason why you also lose weight. And empagliflozin, if you look at historically, it was probably the newest kid on the block, but it it took much better in terms of cardiovascular outcome, because it was the first CVOT to come out for the SGLT2 inhibitors. If you look at the development of SGLT2 inhibitors, dapagliflozin was probably the oldest. Remo and dapa were probably the oldest. Remo at that time was being developed by GlaxoSmithKline, GSK, and subsequently with the rosiglitazone fiasco, they gave up their anti-diabetic portfolio. So Remo did not go into subsequent phase 3 trials. It stopped at phase 2. While dapa was the oldest, Cana was also among the old ones, but Cana was the one which finally got the approval first. And you can see the first papers in each of these in EMPA came only around 2012. But because of its pioneering CVOT, it has got the importance that it's currently having. In terms of pharmacological properties, I think almost all the drugs are very similar. If you look at the major difference between empagliflozin and its competitors. Now, empagliflozin is you can see it is it's a newer drug. That means DAPA, we started with DAPA. When they started with DAPA, they realized that all these SGLT2 inhibitors have both SGLT1 and SGLT2 inhibition. So they tried to make molecules which are more selective for SGLT1 compared to SGLT2. So that is why you can see the evolvement. Dapagliflozin is probably the least selective for SGLT1 versus SGLT2. And as we go, canagliflozin and then subsequently empagliflozin, they get more and more selective. That is because you have now tried and devised a chemical which is more selective to SGLT1 compared to SGLT2. Otherwise, very similar activity in terms of pharmacodynamics and pharmacotherapeutics. You can see some of them have to be given twice a day. Most of them have to be given once a day. And with canagliflozin, we get more glucose excretion per day. It's primarily because it has got some degree of SGLT2 inhibition as well. So that means it is not that selective. There is both SGLT1 and SGLT2. So more glucose is lost in the urine. In addition to losing glucose in the urine, SGLT2, you have to remember, is also a glucose transporter within the gut. So you will end up losing some amount of glucose in the gut when you use a drug which has both SGLT1 and SGLT2 inhibition. So this selectivity is primarily the main differentiation between the currently available SGLT2 inhibitors. Now coming to efficacy, I think all of us know that, or most of us who have heard any talk on SGLT2 inhibitors know that they are very effective. And the effectiveness is not seen so clearly in terms of the clinical trials that you see. And the reason why we don't see that significant decline in HbA1c, here you can see it is almost very similar to a DPP4 inhibitor or primarily a DPP4 inhibitor. If you look at all the studies that have been done, you can see the reduction in HbA1c is about 0.7 to 0.8% or 0.6%. This is various studies as monotherapy, as combination with metformin, combination with pioglitazone, along with insulin with metformin. But all of them, you can see it produces HbA1c about 0.7%. But you have to remember, this is on a background HbA1c or a basal HbA1c. This is, if you can pay attention to the lowest line, this line shows you that most of them have HbA1c between, let's say, 7.8 to a maximum of 8%. So this is something now that we have very clearly understood, that the lower your HbA1c is, the lesser the SGLT2 inhibitors are effective. That means if you have somebody with an HbA1c of 10, it can reduce HbA1c by as high as 2.5%. But if your HbA1c is very close to normal, it is 7.5, 7.7, it is not going to be that effective. And it's easy to understand why that is so, because if your sugars are very close to normal, you're not going to have a great degree of glycosuria. And because you don't have glycosuria, your blood glucose lowering capacity is also reduced. And the higher your glucose is, the more your blood glucose lowering capacity, more glucose is lost in the urine. And that is the reason why it is more effective with higher HbA1c. So with that, the same holds true for weight loss as well. So the higher your HbA1c, more glucose you will lose, more you will lose weight. But in the clinical trials, where most of the time your HbA1c was about 8%, you can see patients lost about 2 to 1.5 to 2 kgs. Almost all the trials, even when they were combined with drugs like pioglitazone. Similar benefits we saw in systolic blood pressure, not really a clinically significant benefit, but statistically in almost all the trials, there was about 3 to 4 millimeter reduction in systolic blood pressure and a reduction of about 1.5 to 2 millimeters of mercury in diastolic blood pressure. Now, this is just to show you that this reduction in blood pressure is over 24 hours. That means over the activity of SGLT2 inhibitors. It is not just a reduction at some parts of the day. So these are ambulatory blood pressure monitoring over 12 weeks. And you can see patients who received both doses of empagliflozin had reduction in blood pressure. And the reduction was throughout the day. So, all through 24 hours, including nocturnal and daytime reduction in blood pressures. And the reduction in blood pressures were not associated with any increases in pulse rate. The other thing that I was talking about, the changes in lipid profile that we see with empagliflozin. Primarily, what we were worried about is there is a slight increase in LDL cholesterol that you see when we give SGLT2 inhibitors, and particularly here you can see that there is an increase. That's the first line that is shaded here. You can see there is an increase in about 3 to 4 milligrams per deciliter of LDL cholesterol. You can equally see almost similar improvements in the good cholesterol, that is HDL cholesterol. So more or less, this increase in LDL cholesterol is compensated by an equal increase in HDL cholesterol. In addition to this increase in HDL cholesterol, the main atherogenic dyslipidemia that we have in Indians is a low HDL cholesterol and a high triglyceride. So there is a significant about 10 milligrams of deciliter decline in triglycerides as well. And that is why the LDL-HDL ratio does not change much at all. So that is just what we wanted to highlight. But again, this is the changes in lipid profile are likely to be beneficial because the cardiovascular outcomes we know from EMPA-REG trial is beneficial for the patient. Now, this is a very crowded slide. I'm not going to look into it, but this is just putting the same things that I showed you in graphs into a table. In a table, it is much, much more difficult to understand, but you can see there is reduction in HbA1c right from 0.4% when it is added to a GLP-1 receptor analog to about 1.5% when it is used as a monotherapy. And the same with body weight, the decline in body weight. This is, some of them are in kgs, some of them are in BMI, so very difficult to interpret. And decline in blood pressure in regardless of what combination you're using with. Now, benefits from my point of view, that is from an endocrinologist point of view, there are the 3 benefits are very clear. Significant benefit on HbA1c, which is going to be higher if the treating or the baseline HbA1c is higher. A weight loss, which is going to be again higher if the baseline HbA1c is higher, but generally you expect about 2 to 3 kilos of weight loss. A statistically significant reduction in blood pressure, but may not be clinically significant. And changes in lipid profile, which on the whole appear to be beneficial, though in terms of numerical numbers, there is a slight increase in total cholesterol and LDL cholesterol, but that seems to be compensated by an increase in HDL cholesterol and a decline in triglycerides. So with this thing, I think there was no doubt that this drug was going to be a very useful drug in our armamentarium for type 2 diabetes. So additionally, what you can see here are the side effect profile. Now, the side effect profile is something that we were always worried about because we were giving a drug that can potentially cause diuresis and natriuresis, and that may lead to dehydration and other issues. But I think what came out from clinical trials is there was no greater amount of adverse events in patients who were on these drugs compared to those who were on placebo, and on patients on placebo would be on other drugs as well. So basically the rate of complications or the rate of adverse events was very similar, those who are taking empagliflozin and those who are not taking empagliflozin, or those who are on placebo. And the worry was urinary infection, but you can very clearly see that there was no increased risk of urinary infection. There was always more chances of getting urinary infection because of your patients having type 2 diabetes. But because you were taking empagliflozin, there was no increased risk. So that is, I think, something very clear in clinical trials. Though in clinical practice, you may see a little more than what we usually see, and that is probably related to poorer genital hygiene and other issues and using it inappropriately. You have to remember, patients in clinical trials are selected very carefully, so they would not have background problems that may make them prone to getting repeated urinary infection, and they also would receive a lot of instructions about how to avoid urinary infection. They might have constant monitoring of urine cultures and things like that to preemptively treat them for urinary infection before they develop severe complications like pyelonephritis or urosepsis. That may be the reason why we did not really see a very high significant difference between a placebo group and the empagliflozin group in terms of urinary tract infection, and more importantly, in terms of severe or serious urinary tract infection like pyelonephritis and urosepsis. So I think clinically, in clinics, we still have to be careful, but in clinical trial, if we maintain a certain standard of care and choose our patients carefully, we are not going to see any increased risk for urinary infection, which is not the case with genital infection, despite the fact most of these patients are given very clear instructions in clinical trials about how to keep genital tract hygiene. There is still a fourfold increased risk of genital tract. That's a genital mycotic infection, almost sevenfold more in females compared to those who are not on empagliflozin, about 3 to 4-fold increased risk in males as well. The other side effects like volume depletion, hypoglycemia, all these were very minor. But then again, you have to remember, these are from clinical trials where patients may not be, they would be very carefully chosen, so they'll be less at risk for volume depletion and other complications like that. Now, again, unless you have not been following any literature or not listening to any webinars or not attended any CMEs in the last 5 years, there is no way you would have not heard of the EMPA-REG outcome trial, because this was the first trial with anti-diabetic agents which gave us cardiovascular benefits. So this is the EMPA-REG trial. Just quickly looking at not the cardiovascular outcome, looking at the renal outcomes. So this is the first time we also realized that in addition to cardiovascular benefits, the SGLT2 inhibitors are also going to give you renal benefits. So here the three things that were looked at is, the more important one is a composite renal outcome, which will not compose of albuminuria, but which will compose of doubling of creatinine, renal death, and requirement for renal replacement therapy. So that is a solid outcome, in like very similar to MACE. Composite renal outcome is a solid outcome for chronic kidney disease, while worsening nephropathy and progression of albuminuria are more softer outcomes, not hard outcomes. But you can see that there is benefits there as well. So again, this is what the type of patients were. And then again, both of them had the patients with type 2 diabetes and high CV risk. Empagliflozin reduced heart failure. Now, this is a class benefit that we see, the reduction in heart failure hospitalization and a combination of heart failure hospitalization with CV death. Looking at the actual 3 MACE was very much protective, primarily contributed by CV death, which was extremely reduced, or in the sense the hazard ratio is 0.62, very much in terms of protection, not so much driven by the non-fatal MIs and non-fatal stroke. 3-point MACE primarily driven by reductions in CV death. Now, this is something that I think when we first read the EMPA-REG outcome, we only saw the survival curves. And what we realized from the survival curve is the improvements in CV death or the improvements in 3-point MACE happened very early. That means it happened within 6 months of starting the drug, or even earlier, within 4 weeks of starting the drug. So this is now exploratory analysis, a post-hoc analysis of the EMPA-REG outcome, trying to see how early these benefits are seen. And these benefits are both in terms of 3-point MACE or in terms of heart failure, CV death. How early or how many weeks after starting the treatment initiation did we see these benefits? And this was presented at this year's online American Diabetes Association as an oral abstract. And what we can see in this graph, it looks very confusing, but what you can see in this particular graph is in terms of hospitalization for heart failure, the effects appeared within 17 days. That is what this graph shows, that patients started deriving benefits from empagliflozin in terms of reduction in the number of times you go to the hospital with heart failure as early as 17 days. So these are some drugs which are giving you benefits very, very early once you start it. And in terms of heart failure or CV death, it took only about 27 days for the graph or for the survival curves to start separating from each other. And that is quite dramatic for a drug which was first planned for hyperglycemia only. Now, these are some findings, very similar findings. The EMPA-REG was a clinical trial, a randomized controlled clinical trial. Now, we also believe that some of these patients may be very ideal patients, not the kind of patients we see in our OPD. That's why now we believe that the benefits what we get from RCTs should also be shown in real world. And that is why now we give importance to real world studies as well. The EMPRISE is a real world study, which basically is comparing empagliflozin with all kinds of DPP-4 inhibitors. And you can see very similar outcome measures that we saw in EMPA-REG. All-cause mortality is greatly benefited. Most of it is driven by, the CV benefits are driven by all-cause mortality, not so much by decrease in myocardial infarction, not so much by stroke, but primarily by CV death. And you can see hospitalization for heart failure is also significantly reduced. So same things that we saw in the RCTs, we also see in the real world. This was also presented as an abstract this year. Now, in terms of CV safety trials, I think more and more are coming. The first positive trial was the EMPA-REG, but subsequently you can see other trials have also come, not showing you that dramatic an impact as EMPA-REG, but other trials have also shown. I think they have missed a few trials. They've definitely not put the Pioneer 6 trial, which is the first trial with an oral GLP-1 agent, which also showed superiority in terms of 3-point MACE. So again, the only disappointment was with ertugliflozin, which did not really show any improvement in 3-point MACE in again a small CVOT. And not surprising that we have, with this kind of data that we have, the guidelines from 2018 have included SGLT2 inhibitors and GLP-1 receptor agonists as first-line drugs or drugs after metformin, irrespective of the levels of HbA1c for patients with high-risk cardiovascular disease or with established atherosclerotic cardiovascular disease. So I think I'll stop here, and I think it's very clear what what benefits my patients with diabetes are going to get. They are going to get primarily benefits in terms of glycemic control, in terms of weight reduction, in terms of blood pressure reduction. And also, if they do not have cardiovascular disease, I'm sure they are going to get benefits in terms of reduction in terms of cardiovascular disease as well. So now I'll be happy to listen to Dr. Sandeep Chopra, who's my friend, who's going to tell us what he thinks in terms of cardiologist perspective. I think all we don't have is now a nephrologist, a gastroenterologist, and a pulmonologist to give us a complete worldview of SGLT2 inhibitors. So welcome, Dr. Sandeep.
Thanks, Dr. Jacob. That was an excellent talk. You made my job very easy, and sorry for the delay in joining you. I was busy, unlike endocrinologists. So I'll be talking about SGLT2 inhibitors, a cardiologist's perspective. So yes, Dr. Jacob, like you said very clearly, that these new drugs are taking the cardiology world by storm, and we who've been I would use the technical term drug naive. We had no idea about diabetic drugs except for glimepiride and metformin. We've had to do a lot of research and attend a lot of webinars to get ourselves, knowledgeable about this drug, because this is a game changer for us as well. So exploratory data has shown that SGLT2 inhibitors have multiple cardiorenal benefits across the entire spectrum of the class, with EMPA, CANA, DAPA, and ER2. So I personally have experience with EMPA and DAPA, and more so with EMPA. So the EMPA-REG outcome you've already delved upon very, very clearly. So going back many years, when we talk about the gold standard study for cardiac patients, the Framingham Heart Study, and there was a high rate of heart failure in patients with diabetes over a 30-year follow-up. And we're all obsessed, we as cardiologists and physicians are obsessed with coronary artery disease, with myocardial infarctions and angina and stroke. But heart failure is a more common outcome than MI, stroke and death in patients with type 2 diabetes. And this has been proven across various trials. So heart failure outcomes have been studied now in these new drugs. So again, we'll skip these slides very fast because the benefit of SGLT2 inhibitors on heart failure patients, on heart failure risk in patients with diabetes has been studied with the EMPA-REG outcome and has been shown to be very, very beneficial. So compared to placebo, the incidence of heart failure is been found to be significantly lower in patients who were on SGLT2 inhibitors in this trial, specifically empagliflozin. So what is the pathophysiology? How is this class of drugs so helpful for cardiac patients? Firstly, they cause natriuresis. They cause improved kidney function and cardiorenal physiology. They reduce preload, afterload, and reduction in LV wall stress, which is the main precipitating factor in heart failure. And most of our drugs, from ACE inhibitors, ARBs, ARNIs, target this pathology of preload and afterload. Beta blockers as well. And they reduce the interstitial edema as well. So just touching for our physician colleagues, what are the drugs we've used for heart failure? Those which prevent heart failure, statins are the gold standards. We add antiplatelets because of the risk of coronary artery disease being so much higher. Appropriate control of blood pressure with calcium channel blockers or thiazides or your choice of drugs. Therapies which treat established heart failure are ARNI, ivabradine, mineralocorticoid receptor antagonists like aldosterone or eplerenone. So you don't use ARNI or ivabradine or eplerenone for preventing heart failure, but you use it to treat established heart failure. And therapies that both treat and prevent heart failure are ACE inhibitors, ARBs, beta blockers, and exercise. So guidelines now, will not get into this. This is Dr. Jacob's domain, but because the slide is provided, the ESC says that drug-naive patients can be started on SGLT2 inhibitors or GLP-1 receptor analogs. And ACC says that consider metformin as first-line therapy, but the ESC says metformin is not necessarily a first-line drug therapy, but I will leave this expert opinion to Dr. Jacob to emphasize on. Going on specifically for heart failure with EMPA, there was an EMPEROR reduced study in which there were patients with reduced EF, and EMPEROR preserved study in which the patients had a EF of more than 40%. So the drug which was studied was EMPA in a dose of 10 milligrams versus a placebo in patients with chronic heart failure and reduced or preserved EF across the world. So next few slides are a repetition of this study. I will straight away get to the crux of it. Basically, the endpoint which was studied was time to first event of adjudicated cardiovascular death or heart failure hospitalization in patients with heart failure with reduced EF. So this was published in the NEJM, and I will again emphasize the primary endpoint being composite or CV death or heart failure hospitalization. The first secondary endpoint was total heart failure hospitalizations, and second secondary endpoint was the renal protection. So total enrollees in this trial were more than 3,500, and the duration of follow-up was around 16 months, and the mean age was around 67 years. The inclusion criteria included age above 18, NYHA class 2, 3, 4, a EF of less than 40%, a heart failure hospitalization within 12 months, and a high NT-proBNP, that is a diagnostic and a prognostic marker for patients with heart failure. Exclusion meant criteria included an acute coronary syndrome or a stroke or a severe valvular heart disease or a patient who's very sick in our ICU with acute decompensated heart failure. So The primary endpoint, which showed a 25% reduction in risk of composite of CV death or heart failure hospitalization, 30% reduction in total heart failure hospitalization, and a significant improvement in the renal functions. So EMPA prevented both serious heart failure and serious kidney failure events. So this trial has major implications for clinical practice and will have a major impact on the management of patients with chronic heart failure and a reduced EF. And the main point here is whether or not they have diabetes. So it's not just our diabetic patients who will benefit from this drug, but non-diabetics as well with established heart failure with a reduced EF. So a repetition again, heart failure for hospitalization and all-cause mortality, there was a significant reduction. So the conclusion was among patients receiving recommended therapy for heart failure, that means the patient is on standard therapy already, those in the empagliflozin group had a lower risk of CV death or hospitalization for heart failure than those in the placebo group. So these patients, even if they are on standard therapy, this is one more, a drug in our armamentarium. All of us should realize that there's a 50% mortality at 5 years for our patients with heart failure. And even if you add few years to our patient's life, not just in the longevity, but the quality of life, that will go a long way in making our patients more comfortable, more healthy, and less prone to a heart failure hospitalization and a reduced risk of mortality. So the results of this trial indicate that EMPA is superior to placebo in patients with symptomatic heart failure with EF of less than 40%, even on those patients who are already on guideline-directed medical therapy. So just adding here, outside the domain of this talk, what do we mean by guideline-directed medical therapy? A patient with heart failure with reduced EF should be on ACE inhibitor or an angiotensin receptor blocker or an ARNI. ARNI means valsartan sacubitril combination. If the patient can afford an ARNI, that is a better drug than ACE inhibitor and an ARB. So make sure you don't add all three together. Any one of them, preferably an ARNI. Then a beta blocker, if the patient can tolerate, that means the heart rate should be around 60 on beta blockers with a good blood pressure. Then you add ivabradine if in spite of the maximal tolerated dose of a beta blocker, the patient's heart rate remains high. Then you add a MRA, mineralocorticoid receptor antagonist like spironolactone and eplerenone. The things like torsemide and furosemide, which we normally give for heart failure in our OPDs and clinics, are not mortality reducing drugs. It is the spironolactone or the eplerenone which will reduce the mortality as a diuretic. So this is a new drug which helps in these patients who are already supposedly squeezed from a cardiologist perspective with the number of drugs that we had, and this is going to go a long way in helping our patients. So our SGLT2 inhibitor is the future of heart failure treatment. I strongly believe so. Yes, it's a class effect, but EMPA, I reckon, has such a good mortality benefit that the benefit of this drug should be given to all your patients from a cardiologist's perspective with EF of less than 40%. Thank you very much.
Thank you. Yeah. Thank you, Dr. Sandeep and Dr. Jubin, for a wonderful presentation. There is a question. Okay. So to Dr. Sandeep, can empagliflozin can be used in multiple CV risk factor patient? Question from the audience.
Yes, please. It can be and should be used.
Yeah. Can we use empagliflozin multiple CV risk factor patient?
Yes, it can be and should be used.
Okay, fine. And there is a question for Jubin. There is a question for Dr. Jubin. Doctor, the audience has asked that after this EMPA-REG trial, so there was a lot of things has come off with empagliflozin. So can we consider empagliflozin at par with metformin if we initiate early?
Okay, so I mean, considering empagliflozin at par with metformin in a type 2 diabetic, I don't think we have reached there. But the ESC guidelines say that if you have heart failure or you have atherosclerotic heart disease, at least the European cardiologists believe that empagliflozin may be superior to metformin. But the American cardiologists still don't believe that. They believe consider metformin first and then empagliflozin. None of the endocrine societies have yet to put any SGLT2 inhibitor in front of metformin. I think still for all patients with type 2 diabetes, the first drug is metformin.
Okay, so next is, what are the safety precautions that endocrinologists should keep in mind when using this SGLT2 inhibitor?
Yeah, I think three things you have to keep in mind. One, should we start the drug? And I should think we should look at each patient carefully and then decide to start the drug. The number one reason you will not start the drug is a patient whose HbA1c is very high and who's likely to be insulinopenic. So if somebody with an HbA1c of 12, 13, 14, who's lost a lot of weight, who's having a lot of hyperosmolar symptoms, then SGLT2 inhibitor is not for him. Insulin is the drug that we should give for him. Otherwise, he may precipitate diabetic ketoacidosis. We should not give to anyone we suspect we may not be dealing with type 2, but type 1 diabetes. The other contraindications are generally relative. Being normal weight is not a contraindication for SGLT2 inhibitors, because I've heard people say that it's only meant for overweight patients. It is not meant for only overweight patients. Being underweight may be a relative contraindication, but being normal weight is not a contraindication. Older patients do not withstand the initial diuresis and natriuresis that happens, and they can get very giddy and can have a fall. So I would generally avoid it in patients over 75. But this is again not a absolute contraindication. There may be a completely active 80-year-old who deserves a drug, and there may be a very frail 65-year-old 65-year-old person in whom I will not use the drug. The history of renal or urinary infection is not a contraindication, but repeated urinary infection, complicated urinary infection is a relative contraindication. On the whole, there are very few patients whom I will not use the drug. Most patients we can use the drug, but what you should be careful is you have to explain to the patient that if the patient gets acutely unwell, patient is having vomiting, patient is going to a hospital with sepsis, patient is going for a surgery, he needs to stop the drug. Otherwise, there is always a risk of precipitating ketoacidosis in these stressful situations. Okay. I think with these two things, I think these are the same things we used to tell patients with ARBs. If you have a gastroenteritis, if you're going to the hospital, it's a good idea to stop the ARB. The same thing I think we should advise the patients on SGLT2 inhibitor.
Okay, Dr. Sandeep, what are in cardiologist perspective, what are the safety precautions to be taken when using SGLT2 inhibitors?
So yes, we need to be careful. When a patient with heart failure comes, we kind of sometimes over-diurese our patients with loop diuretics. So dehydration can be a complicating risk factor. We need to be very careful about the fluid status of our patients. Yes, it's a new drug, but over the last couple of years, we've learned how to handle it, and we are pretty successful now. So make sure the patient is not very dry. We're not in a very negative balance from a urine output point of view. Otherwise, we're not facing any major issues as such.
Okay. Thank you. There is no more questions, so we are just concluding the session. Okay, thank you, Dr. Jacob and Dr. Sandeep, for your wonderful presentation, sharing your experience. And on behalf of Lupin, we thank you and take care. We'll catch you in the future meetings.
Thank you, Dr. Jacob. Thank you. Yeah. Thank you, Dr. Shavik.
Yeah.